Hello, my name is Theodore Awad and I am excited to present to you our work on incrementally semi-supervised classification of arthritis inflammation on a clinical dataset. It was accepted at the International Conference on Image Processing 2022. First, we present the disease at hand and the cohort we use. We show the method we use to improve the weak annotations of these cohorts to prepare the data. Then, we present how we use these annotations to automate patient diagnosis. We present our results, and finally we conclude and give insights for future work. The objective of this article is to show how relatively rare disease can benefit from modern machine learning techniques, even when the annotations are weak and sparse. Axial spondyloarthritis, or AxSpA, is the most common inflammatory rheumatism in young men. It is painful and includes long-term inflammation of the spine. It sometimes presents early signs of presence in MRI. It is relatively rare and hard to detect, needing a radiologist expert in musculoskeletal imaging to be diagnosed. Can we use machine learning techniques to automate AxSpA detection? The DESIR cohort was created to study AxSpA. Patients were recruited and followed for 10 years. For each patient, T1 and T memory sequences were gathered with 12 to 18 slices. The images were gathered across 20 different institutions, resulting in variable image quality. Each MRI slice was annotated by 3 expert radiologist readers. They annotate if each joint is inflamed or not in 6 different slices. They also give a total opinion for patients. We have 2 types of annotations, one for the whole patient and one for each joint region. We focus only on the patients where all 3 readers agree on the diagnosis. Finally, on these patients, almost 300 did not have perfectly aligned T1 and STIR and were unusable. The annotations are binary. Either a region is inflamed or not, or either a patient is sick or not. Therefore, we have weak annotation. The first naive approach is to try to predict either the sickness of a region or a patient using the raw images. However, MRIs are too complicated for this method to work with only 288 patients. Therefore, we enrich the annotations with clinical information. Expert knowledge tells us that the signs of AxSpA are inside the joint region. Therefore, to prepare the classification algorithm, first we try and detect these regions. We define a 2-step process. First, we segment the bones using deep learning, so the iliac and sacrum bone. Then, we use mathematical morphology to derive the region of interest. We first start by applying some preprocessing. We ensure that each pixel has the same spatial information. Then, we remove a classical low-frequency MRI bias that depends on the machine. We denoise a little with a median filter, and finally apply histogram equalization. Here are the results of this preprocessing for one example. For bone segmentation, we use deep learning. We ask expert radiologists to segment the iliac and sacrum bone of 51 patients. The trained val-eval split is 36, 6, and 14. We find in practice that training 1 unit per bone is better. Indeed, some slices present no sacrum, and this can be a difficulty. We use a weighted binary cross-entropy loss, with weights 0.1 for background and 0.9 for foreground, and augment the data with random rotation and horizontal flip. Finally, once the model is trained, we apply it to the remaining 237 patients. Here we can see one example of a success and one example of a failure. Now that the segmentation is done, we define a mathematical morphology pipeline to derive the ROI. We see that the segmentation is not perfect. Some artifacts can be seen on some places. Therefore, our pipeline must be robust to these imperfections. First, we look at all possible iliac regions that are next to a sacrum. Then we delete the wings as they are useless in the region of interest. Then we dilate the iliac to be sure not to lose any information. Then we dilate the iliac horizontally to go and catch the sacrum that is next to it. Finally, we close the joint and fill the holes to ensure that we have a nice consistent region of interest. Then for each side we take the largest region of interest found with this method to ensure that we only have 2 regions of interest per slice. We apply this pipeline to the resulting segmentation. A radiologist evaluates the final predicted ROI. If it contains the relevant information for the detection of the disease, we say that it is a success. We have a success on 205 people. This increases the number of patients we have manually segmented to 256. To summarize, we have manually segmented 51 MRIs, used 2 units, one for each bone, to segment 205 more patients, resulting in a total of 256 patients. This results in a total of 3,770 regions of interest plus diagnosis that can be used as strong labels to train an automated classification network. The automated patient diagnosis is also performed in a 2-step process. First, we perform the ROI classification using deep learning for each individual slice. Then, in the second step, we perform patient diagnosis by aggregating each result of each slide using a hard-coded decision rule. The ROI classification is done with the mask RCNN. As it does both segmentation and classification, for training we need both the ROI segmentation and its label. Therefore, we use the previously gathered ROIs and the label comes from the reader's vote. The train test split is as follows, with 178 people to train with 2,035 slices. And for validation we have 25 to 281, and for evaluation we have 53 and 597. Once the ROIs are classified, for each patient we know where are its inflamed lesions. The decision rules derived from clinical practice is as follows. If there are at least 2 lesions, the patient is positive. Now let's see the results. We present the MCC, the Matthews Correlation Coefficient. It is between -1 and 1. If it is 1, it's perfect. If it's -1, it's the worst possible situation. And if it's at 0, it's random prediction. We show the results on the 53 evaluation patients on the ROI. The consensus means the votes between the 3 readers. We train 10 identical networks to analyze the robustness to initialization. To read this table, we can see, for example, that if we compare reader 2 to reader 3, the MCC is 67%. Now if we compare the model mask RCNN to the consensus, which is our value of interest, the MCC is at 60. We can compare it to the MCC of the readers between each other. It yields quite good results, despite being still lower than the radiologist's opinion. We present the same table for automated patient diagnosis after aggregation of slices. We remind that the readers agree for patient diagnosis. It was our inclusion criterion. To compare readers between each other, we use all of the DESIR cohort patients, including those who are difficult. Therefore, we underestimate the readers' performance against the model, as the model does not see these difficult patients. We call ensembling the votes of the 10 networks, and it's only wrong on 2 patients, with a high MCC at 90%. We conclude that this model gives a valid opinion on detection of AxSpA in MRI. We also show our results on an external dataset called ASAS dataset that follows the same protocol as DESIR. We show patient diagnosis results. The ensembling reaches 62% MCC on the consensus, whereas the inter-reader comparison is at 70%. Therefore, the model can generalize quite well, while not perfectly, to new datasets. Finally, we show an ablation study of the preprocessing as well as the addition of our 201 automated segmented patients. First, we see that if we did not add these patients, and we only use our 51 manually segmented patients, the GRNCC would drop to 70% compared to 90%, whereas the ASAS NCC would drop to 21%, which would be a big drop from our 62%. This shows the importance of our incremented data. We can also see the importance of the preprocessing, particularly on the generalization to the external datasets. To conclude, our model can detect AxSpA with performance close to radiologists and even generalizes to new datasets. The expensive annotation, the segmentation, is done only for bones. It doesn't need experts' knowledge. For future work, we will further validate the results on more external datasets. We will work on the explainability of the model and improve the inclusion criterion to increase the number of training patients for DESIR cohorts. Thank you for your attention. If you have any questions, please don't hesitate to ask.